Well, good morning or good afternoon, depending on what time zone you came from. Delighted to be here. I realize that I am the only thing standing between you and lunch. So I will try to keep this focused on a 30,000 view of a big blockchain use case. And I'd like to make sure we have some time at the end for maybe some Q&A before we spill over into lunch. So let me see if I can get is there a clicker, or is someone being the clicker for me? Do we know? Oh, I hear one coming. Thank you. Thank you. Perfect. Thanks. So what I want to talk about this afternoon is moving to the third curve, and I'll get to that in a minute, and I'll get to why I think this has a lot to do why all of you are here today for this conference. So in the United States today, we have a supply and a demand problem. The burden of chronic disease in this country is increasing at twice the rate of population growth. And the population is getting older literally by the day. In fact, 1 out of every 5 Americans will be over the age of 65 by 2040. It's inevitable that both will drive up healthcare demand and services, but also inevitably healthcare cost. And at the same time, in terms of supply, the physician shortfall in this country is worsening. You go to virtually any community in this country, and trying to find certain specialized services is an enormous challenge. Wait times to see a dermatologist, a neurologist, you can go on down the list. Primary care in many communities is a huge challenge. That's bad news, but the worst news is that it's projected by the AAMC, the Association of American Medical Colleges, that by 2025, this shortage will only get worse, such that we'll be short roughly 90,000 physicians in the US, roughly 10% of the entire US physician workforce at the present time. At the present time. Is the way that we deliver healthcare today necessarily the best way to deliver it in the future? And does blockchain offer a promise for how to allow us to advance that type of move to the third curve in a much better way? So here's a map, or a graph, I should say, and it's in a sense a map because you see all these OECD nations on it. I know there isn't a person in the room that hasn't heard that on a per capita basis, in terms of spending on healthcare, the US is #1 per individual healthcare spending. And here we are. US, this is 2014 OECD data. We are 16.4% of the GDP. It's higher now, as you know. It's over 17%, probably 18%. But this shows something else. This shows not just healthcare spending. This also shows spending for social services. And when you add the two together, we spend about 35% of our GDP on a combination of healthcare and social service spending. And in fact, if you compare us to other OECD nations, we're today about 14th in that group. France, which is #1, and most of the northern European countries are alongside them, spends about 12% of their GDP on healthcare and 31% on social services, adding up to about 43%. That's interesting, but what's even more interesting is that 2/3 of our allocation is on healthcare and 1/3 is on social services. That's the flip of virtually every country on this chart, with the exception of perhaps Korea and Mexico. Do we have an opportunity to think holistically about a way to drive care that is not just about healthcare spending per se and the delivery of healthcare services, but also incorporates social services? And in a country like ours, where individual freedom is valued greatly and the types of systems that exist in some of those other countries are not in place, quite frankly. Does blockchain and other technologies offer us opportunities to get America into a place where we can front load the spending on a number of things in addition to and beyond healthcare per se? And why is that important? So this slide is taken from a talk given by Steve Schroeder, the former president of the Robert Wood Johnson Foundation. And that talk was originally developed from data around 2001 by McGinnis and colleagues. And what Steve said is, health is influenced by factors in 5 domains. And as he said, medical care has a relatively minor role, in fact, 10%. So, genetic predisposition, precision medicine, 30%. But 30% of what? So the outcome measures here are 2 things. 1, premature death. At Aetna, we have hundreds and hundreds and hundreds of actuaries. And they can calculate for each year you were born, based on gender, what the likelihood of you living to a certain age is. Right now, rough numbers, 79 and 83. Rough numbers on average for the entire distribution of the population. The other factor is how you rate your own health, the other variable. And typically you get a Likert scale. And the question is, today, how do you rate your own health? And there are a lot of different ways to do this. The World Health Organization, 70-odd years ago, developed a notion of healthy days, which looks back at a month. And in the past 30 days, how many days did you not have good health? There are a lot of different ways to measure this. Some are obviously more data-driven, others are more global. But at the end of the day, do you live to the age you're predicted to live to, and how you rate your own health on some kind of a Likert scale? Healthcare contributes to roughly 10% of that. Genetics, the hand you were dealt by your parents, contributes to about 30%. And everything else suggests that your zip code has more to do with your health than your genetic code. So, social circumstances, 15%. Poverty, lack of education, lack of health insurance. No sidewalks or bike paths. Living in food deserts. Do you purchase your food at a gas station mini-mart because there is no supermarket nearby? There are no fruits and vegetables. There are no healthy choices for you. Social isolation, crime. Are you fearful of walking outside your home because literally you could get shot? And then why are we surprised that you're obese and you don't get exercise? Environmental factors. When I used to present this information, I sometimes had to, struggle for a couple of minutes to come up with environmental examples of poor health. Living on top of a radon mine in central Pennsylvania. I used to run a large health system in central Pennsylvania. Sadly, I have a much better example that everybody gets instantaneously. Living in Flint, Michigan, having your water contaminated by lead. Epidemiologic studies have shown that a large amount of lead in the water can lead to cognitive and developmental delays in children. That will have an impact, it's been shown later in life, in terms of their well-being. And then, of course, the biggest contributor to outcomes of health are behavioral patterns. So let me ask the audience, this is audience participation, what is the #1 behavioral pattern cause of poor health in this country? Cigarette smoking. I'm a pulmonologist, I still got to practice a little bit. Cigarette smoking. Roughly 16–18% of the population still smokes. It is the #1 contributor. #2, obesity/lack of exercise. Those two together are the 2 largest contributors to that last box, 40% of health status. So what can we say about this? We know what we spend on social services. We know what we spend on health care. We know what health care contributes to someone's ability to achieve their aspirations for better health, and quite frankly, what might be my aspiration, which is to run 25 miles a week, versus someone else whose aspiration might be to walk across the room to pick up their grandchild are different, but they're still their health aspirations and how they rate their health, and how we have to work to allow individuals to achieve their aspirations for better health. So that's very important. But here's what's really amazing to me. 10% of health status is determined by health care. I showed you that first slide. 17% of GDP is spent on health care. It's roughly $3.2 trillion a year. That's what it was in 2015. And study after study has shown that about a third of it goes to total waste. Total waste. $600 billion a year is administrative inefficiency. $400 billion a year is clinical inefficiency. I could make an entire talk out of the examples on the right side of the page, but it's administrative complexity, it's overtreatment, it's fraud, it's improper care, pricing failures, uncoordinated care. Anybody see any opportunities here? So now, imagine if you could take $1 trillion of waste, or some part of it, because it'll never be zero, and repurpose that towards the social determinants of health, the behavioral determinants of health, and the environmental determinants of health. Imagine that value, and I know you're all here talking about value. Imagine that value proposition. It's enormous. That's the opportunity. That's what we have to focus on. Now, anyone that's sitting on $1 trillion bubble, I would argue, is ready for disruption. And we've seen disruption occur in a number of different industries already. We've seen traditional department stores get put out of business by large big box department stores that are now getting put out of business by enterprises that will deliver your household goods on a drone or something. We've seen major airlines get put out of business by low-cost airlines, now getting challenged by regional airlines. We've seen mainframe computers. My dad was a lifer at IBM. Challenged by desktops, now being challenged by cell phones, soon to be challenged by watches. Aetna, by the way, has an exclusive partnership with Aetna using their watches for something I'll talk about later. Tremendous opportunity to take what had originally been in the periphery, and this is what Clay Christensen has talked about in the concept of disruptive innovation. Abacuses get very sophisticated, become mainframe computers, and what do? They move out to the periphery. I ran a large hospital health system. I used to run a medical intensive care unit earlier in my career. I think those are enormously important. But we've seen over time everything move from the periphery. Before there were hospitals, there actually was a time when there were no hospitals. All care was in the home. Everything has migrated to the epicenter of large complexes that are often bricks and mortar. Do we really believe that healthcare, the largest segment of the US economy, is immune to disruption, particularly when it's sitting on top of $1 trillion bubble? I'll let you decide that. So we're going through this change, and this change can really be defined by a series of curves. The health futurist Ian Morrison has talked about healthcare moving from the first curve to the second curve. The first curve being fee-for-service medicine. Aetna has been around since 1853. It wrote its first health policy in 1899. In 1899, a health policy was basically catastrophic health insurance. 1964 comes along, there's something called Medicare and Medicaid. All of a sudden, insurance companies become payers. It is the only industry I know of where insurance companies pay for things like health care. My homeowner's insurance company does not pay for my light bulbs. My car insurance company doesn't pay, for me to go and get an annual checkup of the car, typically. So insurance has migrated to a system of payments, and that's what we've seen. And in the first curve, as that has developed, and it has been amplified to what it is today, we are now in a state of fee for volume. It's not sustainable, obviously. So as Morrison has said, the second curve evolved. The second curve being one in which instead of paying for volume, there's now a pay for performance. And that's the result of many things that everybody in this room, from the Affordable Care Act on, is familiar with. But it's paying for performance that rewards healthcare organizations for achieving predefined goals related to patient outcomes and experience. The term population health has been attached to the second curve along the way. But in many ways, if you think about Christensen's original definition of disruptive innovation, it's about existing organizations that are trying to transform themselves so that they will be here in 10, 20, and 30 years from now to do the things that they do. And I would argue that we are quickly moving to the third curve. Now, I'm not here to tell you that fee-for-service will go away in the next several years, and I'm not telling you certainly that population health and the organizations that are participating in this, spending huge resources to become integrated delivery systems, I ran one myself, and doing all that work are not going to be here. They will. But contemporaneously, we will see the evolution of this third curve, which I would argue is the greatest opportunity you all who are thinking about blockchain have in this room. So why do I believe this? We call it consumer-driven healthcare, but frankly, it's not consumer-driven healthcare, it's personalized healthcare. It's about innovation, and it's about technology, and it's about shifting demographic expectations. Millennials don't go into banks. They use Venmo. They rarely go into big box stores. They use Amazon or the equivalents. I'm not here to particularly identify any resource. I think there are many, but those are two that come to mind. And certainly, they don't stand on busy street corners in New York, where I spend time, waving at yellow vehicles passing them by to get their transportation. So as those millennials get older, and they sadly will start to take on the first curve I showed you of increasing chronic disease as they age, do we really believe that they're going to want to wait 6 weeks for a doctor's appointment? Do we believe that they're going to want to sit in the doctor's office for 3 hours waiting to be seen? I could sit here all day long and tell you nothing's going to change, but I am 100% confident that that demographic shift will have more to do with anything else we see than even that big bubble I showed you several slides back. It's a reality, and the opportunity for all of us in healthcare is to think about how we can develop the solutions that move from, quite frankly, what is a provider or a physician, and I say this as a doctor that still gets to practice a little bit, universe, to a patient or individual-centric universe. That's our greatest opportunity because, quite frankly, it's going to happen. And I'll just give you a few examples. In telemedicine alone, 48% of employers have made telemedicine available to their employees in 2015, and we're already seeing that now increase. At Aetna, in the states where it's permitted, for $35, you can have 2 visits with a dermatologist on your end user device. So you can take a photo and get a diagnosis. And if it's not what they need, they can go see a dermatologist. But imagine that convenience. Imagine not having to wait 6 weeks for an appointment. Imagine getting, within 24 hours, a diagnosis back. In digital health, the digital health global market is expected to exceed $30 billion by 2020. And remote patient monitoring is expected to save $36 billion globally by next year. In concierge medicine, something that typically is available to those with wealth and access to resources, we are now seeing solutions from what I would call third curve health enterprises offer this to those that don't have enormous wealth or can afford a concierge doctors. Iora Health, for example, launched in Boston, is offering solutions across the US. ChenMed in Florida is now growing, offering solutions for a geriatric population that are different, I should say, than the typical delivery system model. And there are many, many other examples, including the one I'll show you in a few minutes at Aetna. So my view of the future is, in the third curve, it's really about moving to this patient-centric universe, this individual-centric universe, and to curate a set of solutions around the individual that focuses on on-demand services, peer-to-peer care networks, and even, quite frankly, if it makes sense, Uberized professional services. It's the opportunity to put the patient in the middle of an array of solutions that are longitudinal and that allow individuals to move along their health journey in ways that create value and can allow for investments up front, because that person will stay with an enterprise, hopefully like Aetna, for years. Currently, in the health insurance industry, the turnover rate is roughly 20% per year. The average member stays with an insurer about 2 years. How do you make investments today that create value over the long run? How can you develop technologies that allow an insurer, healthcare company, however you want to define it, to have long-term relationships with members that create the solutions that they need in real time, but do it over a longitudinal span so that it's a health journey to improve, ultimately, health status, and to do it with an array of solutions that create true value and eliminate waste. This is our view of the future. It's how Aetna plans to transform itself from a health insurance company to a healthcare company by moving to this third curve. So this isn't just theoretical. We've launched this. This was launched earlier this year in our first market in New Jersey. It's called Aetna Care. We are evolving this to an entire member experience. So why an entire member experience as opposed to what we're doing here, and we're going to be scaling this? Aetna today has 50 million members, roughly, of which about 23 million are medical members. The balance are pharmacy, dental, vision, and an assortment of other things. Of our medical members, 75% or so are healthy. They're about 20% of our spend. The balance, 25%, have either acute or chronic illness. 1/5 of that 25% have acute illness, 1/5. And the rest, that other 20% of the total, have chronic illness. Of that 5% of the total with acute illness, that accounts for roughly about 35% of our overall spend as a company. And of the 20% with ongoing chronic illness, it's about 45% of the spend. So imagine a set of solutions that addresses opportunities, particularly those for chronic illness, and the chronic illness that we always think of first is type 2 diabetes, for example, complex patients with metabolic disease, but there are many others on that list, where we can, built on an integrated information exchange platform, have 5 pillars that really address these opportunities. So the first is analytics, identifying the individuals that will benefit the most from the type of experience that I'm going to show you here in a minute. And for those that are otherwise healthy, that 75%, offering them solutions that are much more like consumer-driven healthcare. In the second pillar, it's about having care maps, and we've developed care maps. We have them right now for disease states like diabetes, and in the future, my hope is we will have a care map for each of you in the room, should you ever need one, that is made up of those 5 determinants of health so that it's tailored to your individual needs. The care maps basically say, what are the things that we need to do to keep someone healthy? And sometimes, remarkably, it's not as complicated as you might think. So, for example, diabetic patients. Within 3 months, 50% of them no longer take their medication. They're not adherent. We know that when a physician writes a prescription for a laboratory test, roughly 1/3 of patients never go in and get the test done. And oftentimes, the physician doesn't even know that these things aren't happening. The physician assumes that they did in fact happen and that the lab test was lost, the patient's taking their meds, but the patient is still sick. And you can imagine all the things that occur. The tests are ordered again, there's delays, the opportunity to intervene doesn't occur. In terms of the medications obviously aren't working. The hemoglobin A1C level is still over 9, it's 10, whatever. The glucose levels are off the charts. So what does the doctor do? Prescribes another drug, typically a more expensive drug because the first one's the generic one or whatever, or a very effective brand drug didn't do what it was supposed to do, so they escalate. Or even worse, now the patient has to go on an intravenous drug. So imagine all that waste that could be disrupted by having care maps where we can identify these opportunities early on. And sometimes it's relatively simple solutions looking for that opportunity, which leads us to the third pillar, care coordination. In many traditional systems, care coordination, called care management, is done telephonically, and the success rate of those interventions is remarkably poor and disappointing. So imagine instead if someone would go into your home and open your medicine cabinets and open your pantries and say, you know what, we've talked to your doctor, and in fact, we find that these are the things you should be doing, so let us help you get them done. Let us help you get back to your primary care doctor, or let us beam in an endocrinologist on your phone or whatever your device is, and let us come up with these solutions in real time, and let's make sure that everybody's talking to everybody else. Today in New Jersey, when our Aetna care nurse, and we have them, we employ them, and they go in the home and they find that the diabetic member is not participating in what we would call healthy nutrition, that nurse calls a nutritionist at a ShopRite store in New Jersey, who then escorts the patient up and down the aisles of the supermarket, helping them identify healthy choices. Again, we need the interoperability of information to make sure these things are happening when they should, and to find the most efficient way to coordinate that kind of care. Which is the fourth pillar, the health ecosystem. And the health ecosystem is really what I just showed you on the preceding slide. It's really connecting all those individuals together and doing so in a way that creates true interoperability, that's longitudinal, and that importantly is actionable for the patient. One of the biggest challenges we have today is that providers own the health information, not patients. And until patients truly own their own health information, and that information is presented to them in a way that's actionable, why are we going to be surprised that they don't do anything with it? And arguably even, and I say this gently, when they have access through a patient portal to an EHR, and what they get are a bunch of numbers that say things like, your BUN is 45, why are we shocked and surprised they don't know what to do with it? Because it's not actionable data. When I get in my car, I see a dashboard. It basically has red, yellow, and green lights. When I got in my car 20 years ago, it had an oil pressure gauge. It had a bunch of numbers on it I couldn't understand. What would you rather have, the oil pressure gauge or a red, yellow, and green light? Now think of anything more important than your health or health care. Why can't all of us have yellow and green and red lights? Why not? Why is it so hard? What is so hard about that? To help solve the problem and to come up with those solutions, we believe that value-based contracts, that having everyone have shared risk in the outcomes, is the best way to achieve this vision. Today, roughly about 50% of all of Aetna's contracts are value-based. We expect that by 2020, 75% of our contracts will be value-based. Today, we have over 300 ACOs in value-based arrangements with us. We have 5 major integrated delivery systems that have joint venture agreements with us for full risk. And we have several dozen value-based contracts with pharma, with device companies, and we believe that's only going to increase. As a matter of fact, we haven't announced them all, but the first one we announced last year is with Merck for Januvia, which is their drug for type 2 diabetes, where they are on a risk base with us against the outcomes of the individual, the patient, the member. And their focus is on adherence. They have tons of data. They have solutions to improve adherence. It's a win-win. How do we make sure that the patient is taking the drug? If the patient stays on the drug, that's great for them. If the patient doesn't stay on the drug, they get escalated to somebody else's drug. If we all share financial risk in that ecosystem, recognizing that the patient, the member, starts out with a deductible of $10,000 a year, I'd say they have a lot of risk. But if everybody that's involved shares in risk, and we tie it down on that end, but we can also tie it down on the information end, the data end, then we can come up with a model that gets us a lot further than this. So the opportunity for shared financial risk and shared and interoperable information that is actionable by patients, I believe offers tremendous value for creating an opportunity for individuals to achieve their aspirations for better health, to take waste out of the system, and to allow us to move to the third curve. Now, I think everybody here is familiar with the challenges we have today. I think that blockchain has opportunities to address that. And I'm not going to spend my remaining -1 minute on all the opportunities for blockchain, but I thought, at least from the perspective of someone that is a former health system CEO and now an executive at one of the large health insurers of this country, I'd give you a perspective on a few of the areas where I think there's tremendous opportunity. So I already spoke about consumer engagement and actionable data, and I think we don't have to go into that. Interoperable data, the opportunity to create these health ecosystems where you bring the right solution at the right time to the right individual that you can do longitudinally, I think is enormous. As I said earlier, we have a number of strategic partnerships with end user devices, with digital solutions, including things like the Apple Watch. Being able to create this Internet of Things and having the data recorded into that repository that's patient-centric, I think is enormous. Another area is adherence in pharmaceutical supply chain, and I know many of you have already talked about the pharmaceutical supply chain in terms of the drugs, the accuracy of the supply, the cost, but also I think opportunities around adherence. Clinical trials is another huge opportunity, as you all know, for blockchain in healthcare, but I think we can extend that to real-world evidence. Pharma is making a huge push in this area. Clinical trials are terrific. I've engaged, and I've lost count in how many. But the opportunity to see what happens to a drug in the field when you reflect on the fact that healthcare is just 10% of the equation and 90% of it is due to other things beyond healthcare, creates this enormous need to collect real-world data on the efficacy of drugs and treatments. Because quite frankly, without it, you really can't peel away the value proposition that those drugs offer in the fullest and best way that you can. Precision medicine, genomics, huge opportunities. Now, in health insurance right now, today, we are a bit removed from having access to anyone's genetic information for a lot of good reasons. But there are enormous opportunities, and again, if you think about the opportunities, use cases in blockchain, to allow that information to exist in a repository and to have it coordinated while still offering all of us the privacy that we expect and deserve in that ecosystem, I would argue is enormous. And then finally, value-based contracting. Doing these value-based contracts with more than a one-to-one relationship is challenging. I gave you a couple of examples a few minutes ago. We work with a pharma company We work with a supermarket chain. We work with 2 different ACOs in New Jersey. Wouldn't it be great if we could all have interoperability of our data at the same time that we could build on longitudinally and ultimately bring it back to the patient in terms of value and do it longitudinally for them as well, I think is enormous. So these are just a few of the examples of where we see some tremendous use cases for blockchain and thinking about how we move to the third curve and thinking about ways that we can really create personalized health for individuals. Now, that said, who's going to pay for all this? How does it get paid for? You can imagine working for a large Fortune 50 company. When I ask that question, I usually get suggestions, and I'm looking at myself when I get the answers back. But there are obviously participants in this ecosystem that all can share in those opportunities because ultimately they share in the risk. There are obviously the technological challenges in terms of how the data is abstracted and shared, the regulatory challenges, which I know many of you are familiar with in this room, the need to develop standards which really don't exist at the present time, and how we can effectively migrate away from existing systems. And again, looking at it from the perspective of a health system CEO, the amount of money that I know in my former life we spent on those systems, and now the additional cost of considering how we create a migration is a bit mind-boggling when many of these organizations are not-for-profit delivery systems. So that too is something that I think is going to have to require tremendous amounts of consideration. But I think the value proposition of solutions that work, that allow individuals to have improved health and outcomes is enormous. And if you believe my premise that we can harvest the waste in the system and repurpose it, I think there are huge opportunities to create these efficiencies and effective ways to deliver care in the future. So with that, I'll stop. I don't know, do we have a minute for questions or two? We'll stop and see if you have any questions. Thank you very much. I really appreciate the opportunity.
Hi, I'm Dr. Pravern with the MedCredits team. So what we're doing is building a decentralized telemedicine platform. And what we found is, in the EU, they have this right to care so that any doctor in the EU can treat any patient in the EU. But when you compare that to the United States, there's a lot of state barriers that are preventing a truly national telemedicine system, both in terms of physician credentials, pharmaceuticals, and insurance coverage. And I know there's the interstate license, but that's a bit of a sort of temporizing measure. So how are we going to get to a truly ubiquitous national telemedicine program?
Yeah, that's a great question, and we're familiar with this because we're an international company and we know the role that telemedicine plays in other countries. I would say this, it starts really with this notion of care begins in the home, and then care is focused on communities. Because I don't believe, and I'd love to be wrong, that we're going to find single solutions that cover 50 states in the United States to address some of the issues you raised. But I think if we're pragmatic about this and we start with a focus on communities, and we say, within that community, how do we create an ecosystem that offers the kind of solutions that are necessary? I think it gets us a lot further down the path. Now, I know that means that there's going to be unevenness, that some communities will be much easier and early adopters for some of these approaches than others. But that should never be an argument not to start the process. Because if we wait for one solution to get everything to work together, I think we're going to have to wait a long time. And why would we want to waste these kind of solutions when they can be used today and are being used, quite frankly, today in a number of places?
I think we're good.
There's a hand over there.
All right, great.
My name is Jiva Pereira. I have a question for you on your risk stratification. Typically, risk stratification involves that you look at the claim data. Are you using any kind of predictive analytics to stratify that?
In terms of risk stratification for our members?
Correct.
Yeah, I mean, it's exactly what we're doing. We're looking at the individuals that have the greatest need, and we have the greatest opportunity to offer solutions for them as opposed to trying to do things in a homogeneous way for 23 million people. Absolutely.
Hi, Will Tesh from HealthLX. My question has to do with Aetna's recent announcement with AppleKit and potential blockchain use cases around holistic care for members. Can you speak to any of that?
You know, I really can't speak to any of that right now specifically. I think that the announcement in itself offers insight around the possibility, and you know, I think there's going to be enormous opportunities to think about how we can achieve what I showed you on an earlier slide. But you know, as I stand here at this moment, I really can't offer any more insights around that.
Hi. You mentioned about Patient Portal and it being an effective tool. How do we get patients to be more active on Patient Portal? I know you said changing the way the platform that they're seeing, but how do they get more involved and more effective in that way?
Yeah, so that's a great question. I think that it's the opportunity to give them data and information that they feel they have control over themselves, and it's an ongoing process. Look, from a physician standpoint, it's enormously challenging today to have enough time to be able to spend with a patient at the end of the visit to go through everything once, let alone even more than once. And I think the systems in place, and some of the development, we've learned this from the ACO relationships we've developed, where you have a healthcare team and there's the opportunity for the patient to get information and then in a rather simple way to say, look, here's where you can go back in real time and find out more, but also gauge your progress. I mean, all these devices nowadays are really about giving you feedback so you can gauge progress. Otherwise, why would you continue to look at your watch, right? That's how they succeed. It's not static, it's longitudinal, and this is where you were today, this is what your goal was, how close are you to getting to your goal? We all do that with our financial information in one form or another. We just haven't, you know, frankly, done it with our health information in ways that are very similar. And if we did, I think we'd be enormously successful.
Question here in the back. Hi, my name's Matt Rose. I'm with Savam. My question's regarding, since you're an international organization working with Europe and the new GDPR regulations, having to delete information, et cetera, with the blockchain solutions, once something's written to a blockchain, if you're working with data, something can't be deleted. So how are you addressing GDPR concerns with implementing your blockchain initiatives? And are you even doing that or looking into that or mainly focusing elsewhere instead of Europe?
So I'm just a country doctor from Hershey, PA. You're going to have to help me with the acronym GDPR.
Sorry, so it's data protection rights for individuals in Europe.
I assume that's what it was. I thought the P might stand for that. You know, again, one of the opportunities here is around data security and patient privacy, and I think any of these solutions that are going to create that kind of interoperability, implicit in that is the understanding that the participants, whoever they are on the various ledgers or however it's set up, have to be able to assume and understand that the data will be private and not corruptible. I'm not sure how else you could do this. Certainly, as we exchange financial information and someone else has genetic information, that has to be achievable.
So out here in the back. So yes, I concur with, it's actually Dr. Rose, I think, as well as Dr. from the med credits. Jonathan Holt, also a physician, I'm a geneticist, in fact. And I think the challenge, I suppose, is the right to have your own information. Is a lot of patients, especially here in Tennessee, don't have iPhones or Apple Watches. And as a country doctor myself, it's like the challenge is that, there's this this reality distortion field of Silicon Valley, but actually that doesn't translate into actually the country, the practice of physicians and patients who don't have the latest gadgets.
Right.
So I think certainly the human user interface, I think, is really critically important. I think blockchain, abstracting all of that away to really be usable and truly self-sovereign digital identities. And I think there's a lot of identity management solutions, and I think Dr. Rose is actually working on one, and the right to be forgotten, I think, is really critical in that, because actually you don't want to, you want to be able to be the right to be forgotten, but I think it really is about self-sovereign and truly self-sovereign digital identities.
Thank you. Am I getting the wave?
Any other questions while I'm back here in the room?
Okay. Well, listen, thanks again very much. It was delightful to be here. I appreciate the opportunity. Have a great day. Thank you.